Good morning, everyone. Welcome back to the 2021 Boston Biomed Device Event. We're so excited that you're here to join us this week. If first time back in person, we hope you're glad to be here as well. I'd like to introduce to you Dr. Caroline Yang. She's here today to talk to you about some very interesting things that they're doing in her hospital and how that involves artificial intelligence and machine learning. And so if you would please give Dr. Yang a very warm welcome.
Hi, everyone. Oh, good. You can hear me because I can hear myself. Very good. Well, good afternoon. Thank you for joining me today. I am really excited to share with you my work that I do at home hospital at the Brigham. And I'm going to speak more about hospital at home, the model, and sort of opportunities for AI and machine learning to be integrated into a lot of the work that we do. So, some topics that I'd like to discuss today. So I'd like to go over what home hospital is, for those who are less familiar with this new model of care, what digital health tools that we're using in our program, and how AI and machine learning are being used currently, but also what opportunities there are to utilize these technologies to enhance care at home. And then talking a little bit about both the challenges and the opportunities around utilizing technology in home hospital, and talking a little bit about the future of hospital at home. So, a little bit about what home hospital is. So, I know you guys are all pretty familiar with the traditional hospitalization model where a patient is admitted into the hospital, they're cared for in the hospital, the resources within the hospital are utilized to care for the patient, and then they're discharged home. In our model, we take care of patients at the same level of care, so they're all considered inpatient level of care, and we provide that in the home. So the way I like to put it is we bring the hospital home to you. We have doctors that go to the patient's home and care for the patient. We have nurses. We provide medications, IV and oral. We do testing on site, so we do lab testing. We can coordinate imaging. So all those resources are still available to us to be deployed for the patient at home. And additionally, I think something really cool that we're able to offer is sort of adjunct services like meal delivery to the patient's home. We provide home health aides, so they sort of have this extra layer of support at home, physical therapy, social work, other resources that you might not think would be available at home, but we're able to integrate into our care. So these are the type of patients that we consider based on all of these different factors. So who qualifies? We decide on our patient, our perfect patient, based on geography, where they live, because obviously we are limited by our ability to be at a patient's home in a certain amount of time to provide prompt care. Diagnosis, so diagnostic clarity, knowing what they have, having a good plan or treatment plan. And then we have to consider comorbidities. We don't currently take people who are on hemodialysis because it's hard to coordinate. It can be challenging to have people with active substance abuse at home because it's hard to make sure that they're not using when they're home. So these are all things that we do consider when we think about what patients we take home. We also consider sort of how frequently they need to be monitored, visited, because we are also limited in some ways by our staff, but we do monitor them remotely all the time. And then we consider their home situation and their supports to make sure that they have the supports they need when we're not in home, to make sure that we have a holistic approach to their care. This is sort of what I was speaking to a little bit about our model. It's very patient-centric. The nurse comes to the home twice a day in person. The physician sees the patient once a day, either virtually or in person. And then they have access to our team 24/7, and we also have paramedics on call, so if they need anything, that's where we get additional support. So this is sort of the meat of it. So I wanted to talk a little bit about what current technology we use in home hospital. So we recently actually rolled over to a more comprehensive software where we're able to integrate multiple functions of our day. So we have now a patient-facing application that you can see here. So it's on a tablet. We have patients go home with a tablet. This application is already on the tablet, and this allows patients to be able to call, text, or video the physician when needed. They can view their own biometric data, which I'll speak to a little bit later. So they can see their own heart rate, they can see their own temperature, and then they also have the ability to sort of get reminders and tasks to do for the day. So drink some water, take this medicine, call this physician. So those types of things are on the tablet available to the patient. Then for me as the clinician, as well as the nurses and the paramedics, we have a clinician-facing side, which is on a web and a mobile app. And on this platform, we're able to see live biometric data. We can see we can set and review alarms based on this data. We do task management, so we talk about what tasks need to be done for this patient. Patient handoff, so we update clinical information about the patient. And then we do some inventory management to manage all our devices that we deploy onto the field. We do also use Microsoft Teams for team communication. So we kind of have our individual chats with different providers to provide care for the patient. And then we do our documentation, coding and billing, orders and labs and imaging is still via the electronic medical record. So as you can see, we're still using multiple platforms. Ideally, we want to continue to consolidate to allow for sort of removal of redundancies. A lot of clinical information is scattered across these platforms, so we just want to really try to streamline everything. So that would be an ultimate goal, but we're working on it. So I'm going to talk a little bit about the remote monitoring devices that we use. So sort of the flagship is our Vital Patch. We use this to monitor their temperature, their pulse, their respiratory rate, and they also have a single lead electrocardiogram that is basically the heart rhythm that you can see on a strip from this patch. And then additionally, we utilize weight scales, oximeters for oxygen levels. We have a fall detection bracelet, blood pressure cuff, and glucometer for point of care testing. So these are all things that we utilize in the home to be able to collect important clinical data. So a little bit about the utilization of AI to interpret biometric data. So I really think the opportunity here is that AI-powered solutions can really help clinicians diagnose abnormalities by detecting sort of deviations from a set baseline. So our current technology, let's say for a certain vital or let's say a pulse, we kind of can see a set baseline based on data that's collected for this patient, and we develop a better sense of how far they're deviating from their own baseline over time. We also, there is the opportunity to compare this to a matched patient baseline, so patients of comorbidities and backgrounds, and seeing where they compare to that patient population to be able to see to sort of predict the trajectory of their clinical course and intervene earlier. And then I think also by analyzing and processing such high volumes of data that is generated by these devices, the technology will be able to extract and present just what's relevant. Because as a physician, I get a ton of data, and I think that's the real challenge, is that it's great that we have so much data, but I need to know what to do with it. And the more patients I see, the more data I have. And the more data I have, the more I can make errors, but B, I think it's just more challenging to negotiate my time across managing so many patients with so much information. This is just a pictorial representation of sort of how I communicate with my team. A lot of this happens on that platform, Microsoft Teams, that I spoke about, but we have communication all the time. And I do think that this is an opportunity to innovate as well, because I think because a lot of clinical data is shared on our communications, in our chats, the free text, things like natural language processing could really allow us to analyze a lot of that free text, that unstructured data, to be able to glean important information and extract important information that we could utilize. And then this is sort of how I communicate with my patients. It's either in person, which is the method that you guys are all familiar with, bedside, in the home, and or virtual. So the moral I think here is that virtual, we have found, is for a lot of people just as good as in person. There are definitely a population of people who would benefit better from in-person versus virtual, the elderly, the hearing impaired, those types of things. But we really like to maximize the use of our virtual platforms so that we are able to scale our services and see more patients because we do have people on the ground. We have the nurses that go there in person. So we do virtual communications by the patient application I explained, the tablet that they have, by text, phone, or video. We do Microsoft Teams has a video or call function, so we're able to utilize that with our nurses and EMTs when they're on site. And then we have the traditional phone method with family members or the patients. So my phone to their phone. To speak a little bit about machine learning in the patient-facing applications, so I really think there's a lot of potential here. We have this tablet, we have this application. I think there's a lot of opportunity for automated triage. So for example, if I had a patient who was feeling short of breath and they were able to, and it was not so urgent, but they were able to interact with their interface, that we could potentially have a survey that screens for symptoms and then process the live biometric data and have the technology sort of compare the two and generate either some sort of predictive analytics or, and I think this generates an opportunity for prescriptive analytics to be able to kind of give advice at a very basic level or to escalate appropriately to the provider when needed. I think that on these applications, we can personalize a lot of it. So we can personalize tasks, reminders, and messages that work for each patient individually. And then I think that there's opportunity to use natural language processing to analyze, the text messages that patients send us. Because again, if I have more patients sending me messages all the time, I need to know what's important. I don't have the time to really go through every chat box and look through and see, is this important or not? So it would be really great if we had technology that could sort of analyze and extract that important information for me. So data is everywhere. For me, it's in the patient's chart. It's in our team communications. It's on we have data in the biometric monitors. We have data in the patient messages. We have data from our in-person and our virtual interactions. And the challenge here is that the data is all structured really differently. There's free text, there's numeric, there's verbal through these conversations. And I think a lot of advances in machine learning and AI can help process, integrate, analyze, and extract that relevant information in a meaningful way so that I'm able to look at all the data from all of these different sources quickly, efficiently, and make decisions based on the data that I'm presented with. And really the crux of it is that it provides really valuable clinical decision support. And I think that's what all of this comes down to, is I really want the technology that I'm utilizing to be able to help me make better decisions. So I really think that data could be used to support me in what I do and to scale what I do. And so what? So with this clinical decision support, I think I'm able to provide higher quality care and for more patients at one time, as I kind of spoke to just a second ago. It allows physicians and other staff resources to focus more on the complex decision making and the human touch aspects of medical care. And I think it's really important to keep that in mind because I do think that with technology, it's not meant to replace what we do, it's just meant to support what we do and allow us to do more for more people. And then with this, we can get actionable insights from all the data that we have. So with AI and ML, the more data I have, or the more data the system has, the better it is and the smarter it is, and it'll refine itself as it has more inputs. And ultimately will allow us to personalize care and improve population and individual outcomes. So like I said, technology cannot replace human touch, but I do feel like it can really enhance and scale it. So other applications of AI within home hospital. So we do some device inventory management. You can see just here on the left is what we used to use when we had sort of our device inventory management was through paper. So we would do a checklist and get sent in a folder to the patient's home, but that list would potentially be shuffled around multiple hands and get lost. Now it's built into that platform that I explained earlier, and so we're able to have it all in one place and have it live updated. In terms of the AI opportunities here, I think it could be built to help alert device or supply shortages so that we're not left without a device when we're trying to admit a patient, and then therefore can't admit the patient or can't monitor them. When a device is due for replacement, so our vital patch is 7 days, so knowing ahead of a time so we don't have like dead space where we're not having any data generated. So having AI sort of be able to predict that, and then to allocate inventory where it is needed, when it is needed. We have 2 hospitals and may have more sites in the future, so we need to know where our devices are, maybe in relation to where our patients are. So I do think there's a lot of opportunity there as well. And then something that I'm working on with our ED, our emergency department, is around patient identification. So we spend a big majority of our time trying to find good candidates for our home hospital program. And I do think the hospital has learned about our program so that now they're starting to reach out to us to get us patients. But I think that being able to build an algorithm to screen and identify appropriate patients, because right now I go through the entire emergency department board at a given time, and I will run reports of the inpatient patients. But that takes a lot of time, and I think that building these algorithms to speed that up is another opportunity to utilize artificial intelligence. So there are definitely, with opportunities and advancements, that there are challenges. I think these are some of the biggest ones that come to mind when I think about the care that I provide in the home. So connectivity is absolutely number one. So I think our devices have to connect to internet, and sometimes those get dropped depending on where the patient lives, depending on their speed of connection. So this is something that we kind of run against a lot, and we have to try to optimize. It's really important to maintain the integrity of the data. This is medical information. We want to make sure that if I'm going to make a decision, that the data I'm getting is reliable and accurate. And so that is super key for when we're looking at what kind of technology we want. We want to make sure that it preserves that integrity. The security of the data is really important. I don't really have to say too much about that. Everyone's medical information is confidential, and people want to keep it that way. And so we don't want, in the interweb for a lot of this information to not be protected. And then in terms of, I spoke to this as well, the abundance of data, there's a lot of it, and there's going to continue to be more of it. And I don't think that's a bad thing. I just think we need to figure out how we process and then utilize that data in a useful way that can actually impact patient outcomes and impact the care that I deliver. And then there's data on multiple platforms. For us, we use 3 or 4, but I do think this is something that the entire healthcare system is working on, is really trying to consolidate all the clinical information into one place, whether it's a hospital that has one EMR and a different hospital that has a different EMR. That's one example, but here we have data kind of in different places, and it's a challenge to have to reconcile everything. And I really want to point out that my decision making as a clinician, if I'm utilizing technology, is really only as good as the data that drives my decision. So I really rely on good data to be able to make good clinical decisions. And so, like I spoke to in the last slide, there's a lot of aspects that can challenge that, but also provide opportunities for people to create solutions. Additional challenges of using tech in the home. There's so much technology, there's so many devices. How do I know which one I want to use? So that's something that we have to vet when we think about which one we're going to use for our patients. We rely on patients and families to engage with the technology, not only to just let it, to have the patch on or to take the blood pressure, but we need them to be comfortable using the video calls, and we need to make sure that they can interact with the interface to take reminders or do tasks. And it's not best suited for every patient. So, the hearing or sight impaired may not be able to utilize the tablet. The dementia patients we have may not be able to utilize the tablet. So either we rely on family or we are heavier on the in-person for them. So again, personalizing, right? Technology isn't for everybody. Telehealth isn't for everybody, but I do think there are folks who would really, really benefit from the opportunities that technology provides. And then, of course, it doesn't replace the human touch, right? So if I need to see a patient, evaluate a patient, there are a lot of things that I can do virtually, but some things I'm just much more comfortable doing in person, and at this point in time, I should do in person. So I think that that's really important to keep in mind as we develop technology. But from challenges come opportunities. So I think as technology inevitably becomes faster, more precise, secure, affordable, a lot of doors are going to open. So, and I think the solutions we're looking for are solutions that are going to reduce redundancies, enhance the seamless integration of data, help us increase our efficiency, so decreasing the cost and time to diagnosis, to treatment. And I think that we really are looking for solutions to optimize the processing and presentation of all of this data we have to really improve the care that we deliver. And then in some specific situations, I think it's appropriate to automate some processes. I don't think we can automate medicine completely, but I do think there are some things that can be automated, that should be automated, and can really help, again, allow me to scale the work that I do. Machine learning, I really think is an opportunity to help us understand and use data. This is more for general healthcare, but it does apply to home hospital. So we know that doctors type in notes, nurses type in notes, free text all the time. It's high volumes of unstructured data. And so I think that something like natural language processing can make that data usable for algorithms to extract meaningful insights, and that with time and more data, the accuracy of this technology will increase. And so as we have more and more data, we just need more efficient ways to review, process, and utilize clinically relevant information. So, home hospital. So I think that home hospital is such a fantastic alternative because we really meet patients where they are. I didn't explain kind of the divide of my work, but I work half-time in the hospital in the traditional inpatient setting. So I'm very familiar with inpatient medicine. That was how I was trained, but I work half-time in the home hospital. So it's been such a great comparison to see patients across the two spectrums, but also the care that I deliver across both scenarios. And so I think that when I see patients at home compared to when I see them in the hospital, that I'm able to see where patients come from. I'm able to meet them where they're at. I'm able to see the supports that they have at home. I'm able to individualize the care based on what I see is the environment that they're in. And I can better understand, why did this disease process occur? Why did this exacerbation occur? How could I potentially utilize the resources they have to prevent it, or provide resources to them that could help prevent it? Again, then enhancing outcomes for these patients. And then, I'm able to engage patients in their care, because think about it. When you go to a hospital, the food is provided to you. You're told when to take your meds. You don't have to remember to take your meds. And then they go home, and then, game on, right? Like it's not the same. But when we see patients at home, we're able to set them up for success because we utilize the resources they have and the supports they have, and we rely on them to do a lot of the work. And they're also much more comfortable and have their guard down because they're in their own environment. I think more so than in the hospital, by being at home, we have, in our technology, we have almost more communication with the patient. So now I'm not necessarily going through a nurse or somebody to tell me or report something to me. I'm able to directly communicate with the patient, and I think they really, really appreciate that. And then it increases access, and this is telehealth in general, for those who maybe are less inclined or less able to be accessing the hospital setting in its traditional form, or even outpatient, even primary care. So I do think that this is a really sweet spot where we can do prevention, we can do evaluation, and we can do treatment. So we can do everything in home hospital to a degree greater than I think in the hospital. So lastly, I'm just gonna kind of give my 2 cents on what I think the future of home hospital is. I think it's around to stay. I think it provides such a valuable alternative both to the patient, to the payer, and also to the hospital, financially, but also I think from a big picture standpoint, quality-wise. So I do think that there is a lot of interest in this model. I think a lot of hospitals are trying to look into growing programs like this. For us, in the last year, we tripled our census, our staffing, and so it's grown crazy big in the last year. And partially maybe because of the pandemic, I think a lot of the reimbursements and stuff have valued a lot of the care that we do. So I think that will continue, and I think it's really opened a door for this to grow. And so I think as this model grows, we're going to need more solutions. We're going to utilize more technology, and that's where I think folks in the audience can brainstorm and really support the work that we do to grow hospital at home. I think this is a model that is quite innovative, and it provides, access, and it provides earlier intervention for people's disease processes. And I do think that provides a lot of value to the healthcare system. So the last thing I'll say is, as we know, artificial intelligence and machine learning are powered by data. And the more data we collect, the smarter the technology will get. And then the smarter the technology gets, the more we'll be able to use it, and then therefore feed back into the cycle. So I really think this can explode. I think we just have to have the right technological solutions to do it right. Because I do think healthcare is challenging because there can be a lot of red tape. The sort of downside can be quite extreme in the sense that people's lives are at stake. But I do think that the upside is also quite the potential for the upside is also quite large. So I think keep all of this in mind, think a little bit more about this new model that maybe it's the first time you've heard about it, but I do think it's here to stay, and I'm really excited to see how it grows in the future. So with that, thank you. I'm happy to take any questions, but I appreciate your time.
Thank you, Doctor. Does anyone have questions, comments?
Dr. Yang,
Yes.
how is this taken care of payment-wise by federal and by private insurance companies? And is this a danger to hospitals, or is this a great expansion and positive value for hospitals?
Very good question. So this changed relatively recently, but CMS did say that they would, so Medicare and Medicaid will reimburse us the equivalent amount for an inpatient stay in the hospital as in the home. And that was huge for the hospital. And that's what really exploded a lot of the growth. Some private payers are, and generally that private payers eventually follow suit just because of the market. But I think they are starting to roll. So there are a few private companies that will also do the same. And as far as your question about the hospital, they have been really supportive of the program. That's how we've been able to grow. We have the funding to grow. Brigham has been really excited about the fact that we basically can take patients home. It opens up beds for the more acute patients to be cared for, especially in the time of COVID when patients can be sicker. And then it's also great because think about it. In the hospital, we've been beyond surge capacity at the Brigham for about a year and a half now. And I think that's going to continue. And I do think that the sense that when you're at home hospital, there's no limit to the number of beds. The number of beds you have is the number of homes there are, the number of patients that qualify. So I think that's like sort of a boundless opportunity that is presented. And I don't think it's unique that Brigham has been at surge. I think a lot of hospitals have been feeling it. So I do think that, hospitals everywhere should really look into, engaging a model like this to provide care for patients that are a good fit.
Looks like we got a couple questions here.
Yeah, thank you. I agree. It was a very informative talk. I have a follow-up question to his question about billing. I'm just thinking about, in terms of your hypotheses about how this could grow in the economy. If indeed CMS is going to pay a similar reimbursement amount for this billing, what does the underlying cost structure look like? Is it more efficient? Is it less expensive for the hospital to provide this? And if so, it seems to be a bit of a bonus, something that would positively grow the model.
Yeah. So I think to answer the last part of your question, because of what I said about there being sort of unlimited beds at home, basically the hospital is growing. They're just increasing their bed size, but in a very unique way. And as far as the cost structure, I think the hospital has been, so we actually did a study in the very beginning. This was actually started as a pilot about 4 or 5 years ago. And we did demonstrate to the hospitals that the overall cost of care at home and the quality, the cost is lower, the quality is the same, or if not better. So it is a lower cost, and even to the patient, patients pay out of pocket less than they would pay to be in the hospital, or at least the same, but it's never more. So I think there's a lot of financial winning here, and I think it's just trying to really make everything super efficient in a way to further decrease the costs that are required to run home hospital, because we already know that the cost to run the hospital is very, very high.
Again, thank you. Great talk. So you said that there are a subset of patients that qualify. Do you have a sense for what percentage of patients? And then do you also have outcome data?
It's interesting. So I work both out of the Brigham and the Faulkner. So the Faulkner is much more of a community hospital, so we tend to get more patients from there because they tend to live more central. Our radius started out being 5 miles, sort of a 5 mile radius, and then we went to 7.5, and now we're at 10 miles, which takes us pretty far. But you will know that the Brigham often gets people from out of town, and so maybe that percentage is a little bit lower, but I would say diagnostically pretty similar. But yeah, I would say we get a pretty good percentage of patients, and now, when I started about a year or so ago with this program, we're seeing 3 to 4 patients a day, and now our team is seeing 16, like 15 to 16. So it's really grown quite a bit. So I think the patients are there, and I do think that it's not really a matter of geography. I think radius is just about maybe increasing the number of diagnoses that we take and increasing the different types of supports we have. So I think that, and it's already happening now. We're able to do sort of IV opiates in the home, and we're able to help with like sort of people who have maybe GI bleeds and get them to their colonoscopies, whereas before we wouldn't take anybody who had a GI bleed. So there's definitely different diagnoses that we can take to grow the program outside of just increasing our geography.
The outcomes data, do you have any outcome data?
Outcomes data?
On what?
On the patient. Like, how do they compare, like the outcomes, how do they compare with inpatient care? Like, do you have any data on that?
Yeah, the outcomes are actually, in that study I referenced that we did, it was actually equal. So the quality of care and the outcomes were not worse.
Okay. Other questions or comments for Dr. Yang?
So, hi, thank you for such a good presentation. My question is, like, when we feel sick, we go to the hospital because we can get like instant care, and if our situation deteriorates, we can like get like very fast care. So in the home health or home hospital, how do you like represent that?
So you mean like if a patient has an emergency, like how do we
Yes,
respond?
that's
Yeah,
correct.
that's definitely something we discuss with patients when we take them. When we screen for patients, like I said, in terms of who qualifies, we won't be taking somebody who we think is at high risk of decompensating. And I think as clinicians, we have a pretty good sense of that based on clinical history, based on the history we take actively, based on their biometric data in the emergency room, for example. So that's sort of the first filter where we'll say we probably wouldn't take somebody that might eventually require ICU care, for example. Now, if they've sort of passed through that qualification, everybody might have an emergency, and it may not even be related to their admission diagnosis. So we have paramedics that we deploy. So what happens is the patient will communicate with us, or a family member will communicate with us. If it's emergent, 911. But if it's urgent, they can contact us, and then we deploy our paramedics. And then those paramedics can do virtual visits with the MD. Let's say it's happening overnight, or the MD can go out afterwards. But there is somebody who will respond generally within 15 to 20 minutes. And again, given the geography, that's possible.
Question here?
Who are those paramedics? Are they our routine
It's an outside-
ambulance force, or is this special from the Brigham?
No, we contract with a company that provides us the paramedics.
And they are one of our local ambulance services or a national? Thank you.
Yeah.
Other questions, comments for Dr. Yang?
So, Dr. Yang, what devices are you currently using in your program?
Yeah.
And what patient populations have you been targeting specifically? Was there certain disease states that you're specifically looking to monitor in this program?
Yeah, so for the disease states, you're asking about the types of diagnoses we take? Okay. So we'll take things like heart failure exacerbation. So we do IV diuresis, or we use medicines to get the fluid off. We'll take infections of all sorts. So we'll do IV antibiotics and eventually transition them. We will do like COPD or asthma exacerbations. So we do almost everything. The ones that are challenging are the ones maybe that need, if they're like having chest pain and potentially could decompensate and have active chest pain and needs a catheterization. Like those aren't types of patients that we would take. But we are really growing. So now, like I was saying earlier, with like colonic bleeds or whatnot, before we might not take them. But if they're stable enough and just need a colonoscopy, we can schedule them for that sort of as an outpatient, but we take them home and then send them for the colonoscopy, and we can still provide that care. So the resources we're enlisting are growing within the hospital, so that allows us to take patients home that we maybe weren't able to take before. And as far as the devices go, so we utilize a variety. I won't speak to the exact ones just for the one that is public is that vital patch we use for the vitals monitoring, and that's the technology we use. But we do use a variety of blood pressure cuffs. And as we switched our software recently, we switched some of the devices that we utilize. So,
how do you manage intravenous therapy in the home?
Yep. So they go home with a peripheral line generally, or we place one. We also can enlist the help of, we use another third party to help us place midlines, PICC lines, or just IVs if we have trouble. But generally, they just get the medicines through the IV. The IV just stays in, it's disconnected, and then they just sort of keep a bandage over it so it doesn't obstruct them. I think he had a follow-up.
Sorry.
Nope, so it depends on the medicine, right? So there's certain IV antibiotics that are a push, so we'll do those, and we do prefer those because they're easier. But things like vancomycin, they hang, right? So they'll run over time. Then we will hang those, and then we have the pump set to run at a certain time, so they can have delayed starts. So we don't have to be there when the med is due. It can just be set up in their PM visit for 9 p.m., and then it will just start to run as long as the patient knows to hook themselves up at like 8:30. Or if they're not capable or we're not sure they are capable, we just keep them hooked up and they just stick with it. But they can actually move around. It's in a bag, so they can move around with the antibiotic pump. And we have oxygen therapy that we send home people with, so they can go home with oxygen. So we definitely can provide certain equipment that they do provide in the hospital. Concentrator. Yep.
I'm just going to stand back here next to this gentleman. Any other questions? Okay, I'm just kidding with you.
Find me after. Yeah, but no, don't hesitate to reach out if you have any questions, or find me after. So I'll be around, but if there's no more questions.
Any other questions?
Oh, go ahead.
What if the patient needs imaging?
Yeah, so we'll send them to the hospital to get the imaging, and then we take them back.
Okay, so so there's no portable system, to be
There
sent?
is. So we can do a portable chest x-ray. That's sort of the one that we will do portably, but we're not taking MRIs to patients' houses. So we will send them to, usually it's the outpatient MRI suite, but we just coordinate that. We set up transportation, we take the patient, and so those logistics we handle and then send them there.
It's not unbiased. I'm making ultrasound. Why couldn't you bring ultrasound? We can do everything.
I should have put a picture up. So not too long ago, I did a incision and drainage of a buttock abscess for a patient at their home on their couch. And I took an ultrasound to their home, and I did a point of care ultrasound. And then that helped guide me to do my incision and drainage. So yes, we can do ultrasound at home for sure.
Yes, we have one case, the patient has a COVID.
Yes.
And then he has to go home. So we send a ultrasound system for him to use for a couple of weeks and to monitor his recuperations.
Oh, okay. Yeah, we don't actually take COVID at this very moment in time. I think during the pandemic, at the very beginning of it, the PPE was like so tight, and we also had a small force, so we didn't want to wipe out, one MD or one nurse. And so we don't take COVID home, but I do think you make a good point, because we're also looking, as we know more about the virus and we have more supplies, that we can actually safely care for patients in the home hospital model, maybe with less direct contact, but with a lot of technology support to provide that care. And I know other systems have kind of looked into it or done something similar.
To wonderful question asker, what hospital are you at where you do that?
No, it is the patient get released from the hospital. We send ultrasound with him to his home. I have a paper, clinical study. Oh, sorry. I don't know. I just provide a device. No, the thing is, basically, his primary care doctor is Dr. Bart, and he's in New York, very famous, And then he had this project. He said, Alice, I like to send this patient home, and I like to monitor him. So I just loaned him a system. So, so that's why. Sorry.
Other questions, comments, thoughts? Got one over here. Oh, okay. Anyone else? Oh.
So typically, going to like regulatory with devices and stuff, I'm not a regulatory professional myself, but when you're validating like AI and machine learning type stuff with the device, sometimes there's been challenges. Can you talk to like, when you guys switched your software and how that would impact you, or if you guys have looked into that at all?
Yeah, so the new software we use definitely engages more of that AI machine learning technology. And as we just started using it probably a couple months ago, we're still generating a lot of that data to be able to meaningfully extract sort of insights from how that technology works and to vet it. So I do think we're still a little bit too early to tell. But I am excited to see kind of as we have more patients, more data is generated, and these algorithms are able to sort of get smarter, that we can therefore have a meaningful review of, that technology.
I think we're about out of time. I appreciate
Sounds
you
good.
coming out, Dr.
Thank
Yang.
you guys
If
so
can-
much for joining me. And let me know if you have any other questions. Feel free to reach out.